immigrant population, immigrant populations, and more.
Okay, great. You guys can hear okay? All right, so I just got back from 4 weeks in Chuk. Does anyone know where Chuk is in this room? Yeah, as we're changing slides. Chuk, if this is California and you go that far to Hawaii, that's a long ways. And you go that far again, you're in the Marshall Islands and you're in Chuk. Some of the highest rates of TB and certainly some of the highest rates of leprosy or Hansen's disease in the world. So I just went on a 4-week village to village, find every case of Hansen's, find every case of tuberculosis, and evaluate. So a lot of what I'm going to talk about, I have 2 things that I've learned from this trip. One, this morning I was so desperate for a cup of coffee. I went to McDonald's and I was like, dang, this is pretty good. And then of course they asked me, are you a senior citizen? I was like, how much? Well, it doesn't cost that much for coffee. But the other thing was, when I went to public health school, we got paired with a mentor. And my mentor was this kind of quirky looking dude. I didn't really recognize him. I didn't know him. And he goes, yeah, Scott Lindquist, you're my mentee and I'm going to mentor you through public health school. And my name is Paul Farmer. I was like, yeah, okay, whoever Paul Farmer is. But he asked me something once. He said, why are you going into international health? There's so much need in our own country. Why don't you go work for a tribe? Which I did, but I still did public health, international health. And it always had public health and international health lately has been about don't be a colonizer, don't go into other countries and do studies when it's a developing country, and don't be a white savior and all this. And I get that. But what I learned from this trip is how to do latent TB infection the right way. So I have learned from my international health on something I'm going to share with you guys today, how to really screen for tuberculosis. By the way, we would get on these boats. There's lucky if you had hot water in the morning. You'd get on these boats, you go out to these village, and then we go set up in a school, or it's an open air, and you sweat all day long. But people come in the front door, they're Chukis, so that's the Federated State of Micronesia, and they come in and they get height and weight. They then get a hemoglobin A1C. Then they get their TST, yeah, it's TST, not interferon gammas, get their TST read. And if that is positive, then you get a chest x-ray. If your diabetes screen is positive, you get a chest x-ray. And if you've been exposed to a case, you get a chest x-ray right there. Like the x-ray machine is no bigger than this laptop. And I sit there and read the x-ray with the patient. I say, this is your heart, these are your lungs. First time they've ever seen an x-ray. And I say, it doesn't look like you have any evidence of TB, and we're gonna put you on therapy for it. And they go to the next table and they get put on therapy, which is, and I'll talk about this in the talk today, INH and rifapentine combo medication. We can't even get that here in the United States. 1 pill once a week, and you do it for 3 months, and then you're treated for TB. We are going to plummet the rate of TB in this part of the world. We've done Marshall Islands, we've done Chuk, and we're gonna do Ponape next. But the point of this is, that's all done right then. Then, when you're done talking about TB, you examine them for leprosy. And if there's no lesions for leprosy, we give them a single dose, well, it's actually 2 pills, of rifapentine. And a study just came out this spring saying if you take rifapentine, it will prevent you from getting Hansen's disease for up to 5 years, probably even longer, because the study's only gone 5 years. And I'm doing this in some of the resource poorest parts of the world. And I'm thinking about this on the way home, thinking, dang, we did a better job screening for TB, leprosy, diabetes without anything than we do here in our own country. So I am going to share some of the things that made that successful. And I'm not going to take you on a trip there. I'm just going to talk about it when we're talking about things today, a very systematic approach based on the epidemiology of how to approach diseases. And that really kind of leads into this. All right, here we go. What are the common infections amongst immigrant populations? Well, you know, the obvious answer is depends on where you're immigrating from. If you're from areas that have high rates of TB or Hansen's disease, that's pretty common. But I'm going to show you the systematic evaluation of refugees and immigrants here in Washington State, and what diseases are we talking about, and what do you have to be aware of. And this is really informed by one of these key health indicators, and we'll go through this, but it's from the Office of Refugee Resettlement, and it's a domestic medical exam during 2018 to 2022, and I'm going to summarize like how common is HIV? Because I think in our own heads, we kind of have opinions about medicine. First of all, we all have the magical ability to know who's going to take their pills. We don't. And we also think we know a lot about what diseases certain ethnic groups or countries have. And I want that to be based on some science, not on some I think. So this is common infections, obviously, amongst this immigrant population. This is who's eligible for an exam here in Washington State. It's within arrival of 30 to 90 days, you get an evaluation whether you're a refugee, you're a special immigrant visa holder, an asylee, someone who's paroled as a refugee or asylee. Let's just say these are folks that are coming from pretty tough circumstances in most cases that don't have a lot of access to healthcare. In Chuk, you can get healthcare if you have money. There is no national healthcare association. By the way, if you come from the Marshall Islands or Chuk, you don't need a visa. You can fly right into SeaTac Airport and go live with your family. So if TB is a big issue, then we are going to have TB outbreaks in the Marshallese community, in the Tri-Cities, and who is going to be responsible for finding it and treating it for people that don't have health care? That's why I went to Chuk, is to see, is there a better way to stop TB coming into the United States rather than paying for it on the back end when there's large outbreaks? And there is. So here we go. The purpose of this exam is really, it's a key step in the path to a new arrival to Washington State. And that through this partnership, they're connected to this exam within 30 to 90 days and follow up any conditions that were identified overseas, if at all. By the way, how many of you know what diseases we screen for when we come through SeaTac? We don't. We don't. If someone looks healthy, they don't screen you for anything. It's not like coming into the United States, you're required as a student or a visitor or anybody else for any exam. So there are some conditions where you're required to have an exam, but we try and identify these conditions that would impact folks as they settle, say, in this area or in Seattle area or Snohomish, et cetera. And it's all about promoting well-being and trying to connect people to a primary care home, maybe the first time they've ever done. Okay, so here's what is in a domestic medical exam. When I say a systematic approach to evaluating foreign-born folks, this is it. So you really should follow up on any conditions identified overseas if they know about them. Do a history and physical exam, get immunizations. That's no small undertaking. They get a screening for emotional wellness. So you can imagine, coming from some conditions, you have a lot of trauma in your life. But you get screened for how is your emotional wellness. You get a CBC, B12, urinalysis, some serum chemistries, a pregnancy test, a newborn screening test if you're a newborn, You get HIV, we'll talk about these, HIV, hepatitis B, hepatitis C. You'll get blood level, TB, syphilis, malaria, and intestinal parasites. Okay, that is the systematic approach. In CHUK, I asked these questions. What about intestinal parasites? What about HIV? What about hepatitis C? And the answer was, we don't have money to screen for those things. So we have no idea how much HIV is here. We don't know how much intestinal parasites is here, et cetera, et cetera. So this is an attempt, if you're coming from an area that doesn't have a lot of resources for healthcare, to get this evaluation as you land here in the United States. Okay, it's used for the following things. Evaluate the success of offering health services to newcomers, understand the health conditions, inform the public health practice and health services for these communities, and then to meet the Office of Refugee Resettlement federal reporting requirements. So there's a lot of reasons we do this too, but for me, it's the humanitarian approach systematically to understand someone's healthcare. All right. So who got a domestic medical exam by the country of origin in their year? And I'll just focus, I'm not sure I have a pointer here for you guys. Yeah. If you look all the way to the right, the largest part of folks coming to the United States was from Afghanistan. And the blue part of this graph is from Ukraine. You can see some of these other countries like Syria, Moldova, Russia, Eritrea, Congo. These make up the largest percent of folks coming into Washington State. It looks very different if you're in New York City or you're in San Francisco, but here's what it looked like in Washington State. And in 2022 is all the way to the right. You can see over that since 2016, what makeup has been from. And a lot of that is politics or war or categorization for refugees and asylees. All right. So by year, what counties are doing the most of this work in Washington State? Because not every county is doing them. You can see the largest county that is doing these evaluations is King County. That makes a lot of sense. A lot of people fly into SeaTac, very large population base. But if you look down here, you can see Benton Franklin is one of these areas where a fair amount of folks are screened every year, 200, give or take. That's not an insignificant number. And if you don't understand these diseases and how to do this, you may be providing less than systematic care for this population. What shouldn't happen is what I call the Starbucks effect. I used to love mom and pop shops, and I used to hate Starbucks, because they were corporate, blah, blah, blah. Then I grew up and realized, hey, if I want my double shot dry cappuccino, whether I get it in Omak or downtown Seattle, it's the same thing. Consistency is very important to Starbucks. Are we the same consistency in public health across the state of Washington? And I will tell you no. As a state epi, I know where some people get treated better than others. Their dry cappuccino is very different sitting in downtown Seattle in a very professional clinic doing evaluations versus someone who doesn't do many. So my job is to make sure we're consistent across the state. And that's what I mean by the Starbucks effect. So the counties listed here are usually very consistent and do a good job because I reevaluate the outcomes of most of these and I give feedback if there's lacking, like something's not done or it's done inappropriately. But smaller counties that don't have a lot of numbers, I think you get hit or miss. It depends on who you saw and how much they understand evaluating someone who's a foreign-born person. Okay. So countries of origin, you can see Afghanistan, like I showed you before, in 2022 was the largest population, Ukraine, Moldovan, Sudan, a mix of other countries, which could be CHUK, Marshall Islands, for example, many different languages. And the country of origin by county depends. So let's focus here on Benton Franklin, which is to me, the bottom right, you can see a large portion of this is still Afghani, but not like the rest of the state. You've got bigger Syrian community here, and you got to understand these diseases in that environment for Syria. Yes, you have Ukraine, you have Sudan, you have Venezuela, etc. So you don't look the same as the rest of the state here if you're from here. And so you have to understand that migration pattern to really get it. All right, who gets these exams? Well, by and large, most people that get this are 0 to 9 years old, so kids. How comfortable are you seeing kids? Okay. I'm a pediatrician by training. I'm also an adult and pediatric ID person, and I did nothing but adult TB cases when I was in Chuk. Not super comfortable with it, but I lean on other people for expertise. You got to be comfortable if you're in primary care to be able to see kids for this evaluation, is my point. Yeah, it's mostly an even split between men and women, but it is mostly younger folks. 44%, it says here, are individuals under 18 years of age, and 13% of this population were pregnant. Remember, part of this exam is to offer a pregnancy test. So some of the medications I'll talk about today, you really got to be aware of how that affects a pregnant woman. So, by the way, just to remind you, so over 10% of this population is pregnant. It's a lot. Hearing and vision and dental problems. You know, I always do these things where we provide healthcare to homeless and we do a big evaluation, and, you know, everyone gets clean clothes and a shower and a haircut and a shave if they need it. And then they get medical and dental evaluation. I'm always amazed that dental is the #1 biggest unmet need in these events when we do them. But here you can see, no surprise, dental is much larger than vision or hearing. They do get hearing and vision evaluation, but dental is the biggest need. One of my, and oh my gosh, in Chuk, do you guys know what betel nut is? It's this little nut that people chew. And let me tell you how they make it. Pop it open, it's a nut, and you put a cigarette in it. You take the filter off, so just the cigarette with all the tobacco, and then you pour lye, L-Y-E, over the top of it, and then you put that in your mouth and you spit it out all day long. The country has signs up everywhere, don't spit betel juice, but they're everywhere. And teeth, gums, just is a huge medical need. So if you're coming from, it's not just Chuk, other parts of the country where you chew this kind of nut, dental problems is a huge issue. And I was amazed. I did not try it, by the way. There were 2 things I did not try. One was dog, D-O-G, did not eat it. And the other was betel nut. Just thought of putting lye in my gums. Oh, thanks. Okay. So the point being, dental care is, so if you, in your practice, how many of you are in primary care? When you see someone with bad teeth, what do you do? What? Yeah. Brush your teeth twice a day, floss. Sorry, they're so bad. No, really, I mean, are we good at coordinating with our dental colleagues to get someone in for dental care? I think that's a weakness, and that's a big part of healthcare that we need to improve. If someone has a great solution, yeah, go ahead. Can someone run a mic to her? Yeah. Yeah. Yeah, I think that model is a great model and leads me to, so I have been working, I don't think she needs a mic. She had a great voice. Can you give Jimmy a mic?
He's
Oh, well, that's probably a dangerous thing to do. Yes, give Jimmy a mic because he's trying to say something and I can't hear it. Oh, thank you. Thank you. So for the live screen, I'm asking, and I know Amy, you're on the live screen. I'm asking, what do we do in primary care or any care when we see someone with really bad dental needs? What kind of models do we have? And so people are starting to share some models, and we're picking it up when they do the mic though, right? Okay. Yeah, go ahead.
Is this on?
Yep.
Yes, my name is Ken Harmio. I'm an anesthesiologist here in town, and I work primarily with pediatric dental. And I have to say, we see a lot of immigrants coming in,
Yep.
full mouth dental rehab. I put the kids to sleep, the dentists do all the work, and there's a steady stream, more and more every day. So they are getting taken care of.
Great. Any other models? There's someone up front here. Yep.
So I'm Alex from Walla Walla. In our clinic, we have care managers embedded in the clinic, and then we have a population health department next door. And so we help coordinate them an appointment with the dentist, and we have community health workers that can drive them if they can't transport.
Dang, that's great. So that's what I was going to say about CHUK. The way we got all these people to get tested for TB is we had community health workers that went out 2 days before the rest of us came. And when we identified them for either having TB disease, where they got a sputum right then and there and got their first dose of medication, they followed up with a community worker every week who made sure that they got things done. There are no dentists in CHUK that were available. So this is something I think we need to think a lot more about. I work 1 day a week as a pediatrician doing primary care in a tribe in Western Washington. I've been doing it now for 22 years. I never missed a clinic, even during COVID. And that's what we did. We built a brand new clinic. We created community health workers, and dentist is under the same roof as the medical. There's also a coffee shop too. And behavioral health and counseling is all under one roof. So that is when I see a kid or a parent with really bad teeth, I personally walk them over to the dentist and make an appointment with them to get their teeth done. The MAs, medical assistants in our clinic for pediatrics, do fluoride varnish. The dentist has shown them to do fluoride varnish along with immunizations and everything. So anyways, you can see how I get off track by this simple thing of just dental is such a huge problem. Okay, don't worry, we'll finish on time. TB screening gets done on everyone that comes in. By the way, I, as the state epi, was part of deciding what gets involved in this screen. So I, really made strong case for all these things we're talking about here. I'm just one of a larger group, but TB screening is a very obvious one. And in this, 12% of individuals who had a medical exam were positive. Okay, now what does that mean? Negative is 88%. And that means you were screened by either an interferon gamma release assay or a TST. So we're going to talk about TB a little bit. So I want us to have the same language so that we can talk the same way. If I have TB and I'm up here giving a talk, Larry, maybe of the group, will be exposed to me if I talk and cough on him, okay? Exposure is an epidemiologic term. It is not a term that we as clinicians should use. It's too loosey-goosey. But an exposure is I have a cavity coughing up viable organisms on the magnitude of hundreds to thousands, and I expose Larry to this airspace. He was exposed. But you'd have to know I was culture positive, et cetera, et cetera. On an airplane, this is what I use. 8-hour flight, 2 seats in front, 2 seats in back, 2 seats to the side. That who is exposed epidemiologically. Okay, so it doesn't mean I got TB and I walk down the center here that you're all exposed. Maybe Larry, because I coughed. When I cough my 100 to maybe 1,000 bugs on you, you breathe them in. You are infected. Okay? There's no vaccine that stops that from going in your mouth. You're infected. And the way I know you're infected is either your skin test is positive or your interferon gamma release assay is positive. Chest x-ray is completely normal. Your exam's normal. It's got 100 bugs in your body. Your immune system contained it, but you're still infected. Positive IGRA, positive skin test. And that's a target to treat that we are failing to do. The obvious things like, okay, 10% of the people that have positive IGRA or skin test go on to develop a big cavity. That's disease. So breathing it in is infection. Getting a cavity is disease. So 10% of these people that we do this medical exam on, well, it's actually 12%, I think, are infected with TB. It used to be 2 out of every 3. Now it's really about 2 out of every 4 or 5 people in the world have TB. They're infected with TB. It is very common in the world, not common here in Washington or Oregon. Okay, but in the people that we're screening systematically, 12%. What do you think the percent positivity rate in CHUK was, by the way? Well, let's do this one. What was the percent positivity of hemoglobin A1Cs for diabetes? Polynesian group. What? It's always safe to say 33%. Yeah, it's about 33%. What percent of those folks had, of everyone screened, had a positive skin test? It's 12% if we're sitting on this end. What about in CHUK? What percent do you think? Huh? Yeah, it's about 35 to maybe 40, 45. It's a lot of people infected with TB, okay? Hansen's disease was much less. But the systematic approach to what you're infected with yields a significant number. If you learn anything from this talk about evaluating people who are foreign-born, you gotta understand TB. Okay, you gotta know how to test someone for TB, and you gotta know what to do if it's positive. And you will by the end of this talk. So not all countries have the same risk. You can see 11% is the average. That's that big brown bar at the top. Some countries much higher, like Congo, Eritrea, Burma, Iraq, Ethiopia. Okay, so there are certainly hot spots of TB in the world. I'm not sure you have to know where those hot spots are, because I wouldn't target every person from Eritrea to have TB. I would just do a TB test on everybody. And I'll talk a bit about this. I have lived with skin tests for the last 4 weeks. I do not like the skin test. It is not a great test. I do think interferon gamma release assays are better. They're not perfect, but they are a lot better. But you know, I'll take it if that's all you got is a skin test. You got to know what to do with these. So, okay. Hepatitis B screening. So about 37% of the people are susceptible for hepatitis B, and evidence of infection is only 2%. Okay, what I mean by that is that 37% needs a vaccine pronto, so they don't get hepatitis B. That we don't have large amounts of hepatitis B coming through our refugee and immigration programs, okay? 2% is significant, and certainly this is the reason why anytime someone delivers a baby, we check mom's hepatitis B status, and if it's positive, then we treat the baby with HBIG right away. So we're pretty good at catching most neonatal transfer of hepatitis B, but in this immigration population, you really got to be aware that a significant amount of folks are susceptible to hepatitis B, and they need hepatitis B vaccine, or they may be infected 2%. Okay, so not small numbers. You look at all countries, 2%. There are some countries that you just know off the top of your head have much higher rates. Asia, which is, you know, a very large grouping of countries, tends to have higher rates, but we don't have in this year a lot of Asian immigration. But Eritrea and Burma, I believe, yes, are 2 areas that are big hotspots. And you get to know your immigration communities and what unique health issues they have. But hepatitis B screening, hepatitis C screening, positive is 1%, negative 97, and you'll go, well, that's not 100%. That's right, we don't catch everybody. But there is not a lot of hepatitis C in this year, this immigration population, but 1% is not insignificant. And hepatitis C, you know, I love, did you guys all have a talk on hepatitis C updates yet? Jimmy, is there one this year? No. Failure. No, guys, like you got short timer syndrome, Jimmy. Are you leaving or something? No, the point is we are now arguing, man, when I first started in ID, we would use these brutal treatments, right? Interferon, pegylated interferon. Now we argue about, oh, something's 95% effective or 99% effective, and the prices come down, and the governor in our state has bought enough for everybody in the state of Washington. You know, it's really one of these diseases. I'm not getting on a soapbox, but I'm going to get on a little bit of it. We freak out about COVID. We freak out about Ebola, but the largest pandemic that's preventable, testable, and treatable, like 95% treatable, is hepatitis C. And we are not doing a good job with that one. It doesn't get the attention that COVID or other diseases like, you know, Ebola get. And here is a chance to be able to do something about that 1%. You test them, and by the way, if you are like, oh, I'm going to get an antibody test, and if it's positive, then I'll draw their blood again and find out what it is. No, you just reflex this stuff. Make sure you're reflexing your testing. So if hepatitis C antibody is positive, it automatically gets RNA tested, and it automatically gets genotype, so we know what genotype it is, so that the results you get is not just antibody. It's like, here's the target and here's the treatment I should use. And then you start them on the treatment. You don't have to be a hepatologist to treat hepatitis C anymore. Here is your chance. 1% of the time, these folks are going to have the need to be treated. And I would work with your public health departments to, if funding or expertise or anything is an issue. Largest pandemic in the world. Well, I guess that's redundant because pandemic is worldwide. Largest pandemic. Been going on for years, and we have not addressed this. Okay. Blah, blah, blah. Okay. Here's the outcome, number of individuals screened. Those that had chronic hepatitis C infection, cleared infection or no infection. You can read these all on your own, but here is a disease. It's got a diagnosis. It's easy. It's a blood test. It's got a treatment. It's really effective. You got to use it though. And you got to know what it is. So here's the populations that had the highest rates. And, you know, Ukraine and former Soviet countries tend to have a lot of hepatitis C right now. So I'm not surprised by that it was really focused in Ukraine. So in Oregon or here, eastern part of the state, is there a large migration of Ukrainians right now? Yes. So pay attention to it when Ukraine pops up on here. These are important things to know about that population. You apply this systematically to anyone that comes across. HIV, less than 1%. Okay, I think everyone's fear is that everyone from around the world has HIV, but we don't have it in our own community. I think that's misinformed. And, you know, looking at these immigration numbers, less than 1% being positive means that HIV is not a huge burden on these communities for a lot of reasons. If you're really that sick with HIV, you're probably not traveling. And it may be in a different country than got captured the years that we did this survey, but HIV is not the biggest problem, okay? Syphilis is more of a problem than HIV. And so everyone gets screened for syphilis. And, you know, syphilis is one of those things, it's like learning the Krebs cycle. I mean, how many gosh darn times do I have to learn the Krebs cycle, you know, in my career? It's like understanding syphilis serologies and testing. It's really complicated. And I would just turn to someone who does a lot of these STIs, unless you're pretty comfortable doing it yourself. UpToDate has a really good algorithm on how to read the values. But if you don't see a lot of syphilis, you see these syphilis serologies once in a while, it's really confusing. Turn to someone for help. But we have, if you don't know this, and if someone hasn't talked about this yet, we have a huge syphilis outbreak in Washington State right now. Huge. Like, I haven't seen as many congenital cases of syphilis that we're seeing right now. That isn't due to this population. 1% of this population is testing positive. Yeah. So gonorrhea, same thing. Not a huge amount, 0%. Okay. We're not finding gonorrhea in this population, less than 1% for chlamydia. Parasite screening though, geez Louise. Now, talk about a confusing part of medicine. And I'm gonna make it super easy for you. The parasites of concern are the ones that are listed here: strongyloides, schistosomiasis, and malaria. Okay, there's all other kinds of critters that can be in your stool, and you know, give me another month and I'll bring my ovum parasite back to this room and you'll go, oh yeah, okay, you got that. Pinworm, whatever. These are the numbers. This is a huge burden. We're talking 3,700. 141 with schistosomiasis and 141 with malaria. These are the ones you got to be aware of and understand where they are, that they're tested straightforward. So how do you diagnose and treat these most common parasites? One, strongyloides, the diagnosis are 3 stool samples. Okay, this is going to be a common theme. 3 stool samples for schistosomiasis, ovum parasite exam. And then malaria is good old thick and thin blood smear. Does the hospital here do thick and thin still, Larry? Does the local lab here do it? Yeah, most of us are sending them out to send out labs, but still it's the most clear gold standard diagnostic is thick and thin. Yes, for all of these things, there is serology, not as useful. There's also PCR and antigens that are tested, and they're okay, but just stick with the gold standard, thick and thin smear for malaria, ovum parasite, and you do ovum parasite times 3, you'll pick up strongyloides and schistosomiasis. Treatment for these things are very complicated. I'm going to give this to you so you have it, and then I'm also going to give you where in the middle of the night you call if you're not sure what to do. Okay. So CDC has this presumptive parasite treatment table. This is it. And it mostly centers around albendazole, and it can be ivermectin for strongyloides or praziquantel. But these are the treatments depending on where you're at. We don't have to go over the detail of these, but these are fairly reasonable medications. Ivermectin is not just for COVID anymore. That's a joke. And the use for strongyloides is great. So here's the dosing. Just keep this chart is what I would recommend you do. And if you're pregnant, here's what you use. Because remember, 12% of the women going through this program will be pregnant. And sometimes you don't treat, and you'll understand it. Okay, so if you're looking for kids too, this is the chart. So these 3 charts, just print this off. You guys get access to these slides, right? Where you can print them off and just have this as your reference. There's no way you're going to memorize this, okay? I look at these charts every time I get one of these diseases. I don't try and memorize all this. Depending on where you're from, Asia, sub-Saharan Africa, the treatment may be different. Okay. Same thing as a presumptive approach to malaria. That is, most malaria, like P. falciparum, or a species that you don't know what it is, but someone says, hey, I see malaria in the thick smear. If you know it's an area with chloroquine resistance, here's your treatment. It's coartem, artemether, or malarone. Quinine sulfate plus doxy is reasonable, but not tolerated really well. The further you get down this list, the less likely. I can tell you I haven't used quinine and Clinda in over a decade because I can treat most of it with coartem and malarone. And these are the general presumptive approach to malaria. Doing a thick and thin smear will help speciate which organism you have. Okay, and you may change your treatment choice based on what it was speciated. So when you get stuck, I am giving you these back room numbers to call to say, hey, dear CDC, believe me, they don't usually let general folks call. It's not easy to get through. These are easy to get through. You just call these numbers for parasites or after hours even. They're great for after hours consultation. Usually when I get a parasite or like something that I'm worried about, drug-resistant malaria, I may just call them and say, hey, what's the latest and greatest coming out of Belize right now? I mean, this person's from Belize. They clearly got a thick and thin smear for malaria. They've been treated one round with Malarone. They're not doing good. What would you guys recommend? So that's the use of this. This is your own personal consultant, if you wish. I mean, you can obviously send this to an ID doc, or if they're sick enough, they're in the hospital, but you can manage these on your own. And here's the back room numbers for both malaria and parasitic diseases. Sometimes it's as great as this. I'll pluck, a patient will bring in a worm and I'm like, I don't know. Because worms, it may be a common worm, but common worms sometimes present very atypically. They look weird. They're a different color, all kinds of stuff. Sometimes I'll just take that worm and I'll put it on a white piece of paper with a dime next to it. I'll take a picture and I'll call these guys and I'll say, what do you think? And they will give me the diagnosis. They're really good about it. And then I say, well, while I got you on the phone, what do you think's the best treatment? And there's a pregnant woman in the house. What do you think about that? I have those charts that I just gave you, but you don't have to get stuck on these things. This is pretty easy. Everyone gets screened for blood lead, 6 months through 16-year-old. You can see how much elevated blood lead. I consider, the big move in pediatrics is any number is too much, right? But when I was growing up, it was anything greater than 10. So that's kind of the extremes. I think it's very reasonable. Anything greater than 1 is an elevated blood level. And you can see 67% of these folks that had blood lead levels were a bit elevated. So don't forget the blood lead component of evaluating someone, especially the kids. And again, remember the largest number in the people that are evaluated are young folks at the bottom of the pyramid. Okay. Lead screening of women. Women have elevated lead levels too. It's not insignificant, 6% with really high levels, especially if they're pregnant. That can spell, developmental problems for kids. So it's good to do these lead screenings. Emotional distress screening, I talked about it earlier. It's a standardized health screens called the RHS 15. Not surprised that this is so high. Behavioral health is a huge part of this population. And knowing where to turn when this screen's positive is a challenge for you in practice. But they're elevated. I mean, everything is above, I think the lowest is 15% here. Yeah, 16%. Yeah, in some areas with much, much higher levels. So the key summary of all these indicators that receive exams is the dental needs outweigh anything. So start having these innovative programs for referring for dental. Have the same type of referral system or help for emotional distress in your practice also. And then be aware of these things like elevated blood, latent TB, chronic hepatitis B, chronic hepatitis C. All right, so let's switch gears here. Because TB is so problematic, I just want to go through it again for you. We're all speaking the same language. Latent TB infection, I didn't say disease, I said infection, is the presence of the bug without signs and symptoms or x-ray findings or anything or sputum samples that are positive. But you are positive because you have breathed them in and they're in your body and your skin test or your quantiferon or T-spot are positive. All right. That's the difference between the two. Pulmonary disease usually means, yeah, your TST or IGRA is positive, but your chest x-ray is not abnormal. So the other parts of this are usually when you have pulmonary TB, you have classic signs of TB, night sweats, coughing up blood, really tired, losing weight. These are the things that don't happen with LTBI. But the minute you tell someone in the healthcare profession, someone has TB infection, even though you use the correct words, they freak out and they're like, am I safe? I mean, it just happened in the clinic I work in. I was in Chuk and they had a person with a positive skin test, but a normal x-ray, and the whole clinic freaked out that they were all exposed to TB, and I had to go back over. No, latent TB infection means you have no disease in your chest, you have a positive skin test or an IGRA, but you're not infectious and you don't have transmissible tuberculosis. It's only when you have pulmonary disease, for the most part. I mean, you can have TB anywhere, big lymph node in your bone or your skin or your urine. But that's the difference between in Chuk, the preferred phrase is sleeping TB for latent TB infection and TB disease for cavitary disease or whatever. Okay, there are certain people that are at higher risk for TB disease. That's people with immune systems that are not good, like HIV infected, kids under 5. The highest risk for getting infected and then developing disease is anyone under 5, much higher than anyone with full-blown AIDS or full-blown bone marrow transplant or anything else. Kids under 5 are the biggest risk factor. So that's who you would target, right? But people that'll go from latent TB infection to TB, and I told you it was about 10% of those infected will go on to have disease over their lifetime. But it's much higher if you're underweight, malnourished, substance abuser, or you're receiving some sort of immune modulator like a tumor necrosis factor antagonist, or you've got high dose steroids for things like Crohn's disease, et cetera. All right. Most likely LTB to TB also includes diabetes. The reason we screen for diabetes in Chuk is because, in my experience, diabetes is one of the biggest risk factors for getting TB. It's also a big risk factor for COVID, but progression on to bad outcome is really diabetes. So how do you test for it? 2 methods. Classic skin test. I already told you I'm not a fan of it. The positive predictive value of a skin test is about a little less than 50%. Flip a coin, you get a better result. Interferon gamma release assays are decent. They're blood draws. They're not foolproof, but they are a good test. I, in 1 month, will get a follow-up to my TB testing regimen since I was exposed to a lot of cases in Chuk, and I will get a quantiferon, okay? Just letting you know. Quantiferons are really recommended in anyone who's had a BCG, which is a vaccine for TB, because that can make your skin test positive. So just get a quantiferon in those folks. That's the clearest recommendation. Things that can cause false positive skin tests, any other mycobacteria that isn't TB. If you're a gardener or you're exposed to a lot of these, it can be a problem, or you've had BCG vaccination. False negatives, your immune system's not working. That's the nice thing about some of these interferon gamma release assays is they'll tell you if your immune system was able to pick up any T cell function. And if not, then you know you're allergic. If your skin test is negative, you don't know you're allergic. So I'm not a salesperson for quantiferon or T-spot, but they are a big advancement in our diagnostic ability over the skin test. Other things that can cause false negatives. One of the worst cases in Chuk, by the way, had a negative skin test, but was exposed to someone in the household, did an x-ray, and they had a huge cavity, and the sputum sample was positive. So skin tests can be false negative, especially if you're young too. And I know there's all these slides on why the skin test isn't a good test. Well, things like overwhelming TB, live virus vaccines like measles, or poor administration technique, all can lead to that. So IGRAs are the preferred method. I'm not going to belabor this. So when someone has a positive skin test, like in Chuk, I'm at the x-ray screen, they got a positive, they get an x-ray. And if that x-ray is normal and their exam is normal, they get traded for sleeping TB or latent TB. That is the way you will handle them in your office. You get a positive, you'll get a chest x-ray. That chest x-ray is normal and you examine them and you don't see any big lymph nodes, then you're going to treat them for LTBI. And I'm going to give you the treatment regimens in a minute here. But initiating treatment is pretty straightforward. What's the risk and benefit of these regimens I'm going to show you? Isoniazid, here you could do isoniazid every day for 9 months. I haven't done this in over a decade. I haven't treated someone with an INH for 9 months because these other regimens like INH plus rifapentine once weekly for 12 doses, such an improved regimen. Again, the regimen we used in CHUK. Or you could do rifampin daily, which is my second back pocket. If they can't take INH and rifapentine, I use rifampin and I do it daily for 4 months, a lot shorter than 9 months. These INH and rifapentine regimen, I've talked to you about it. You can't use it in kids under 12. And it should be directly observed therapy. We've just done studies now saying that, nope, you can just give out once a week dosing. You can have the pharmacist dispense it once a week, and you'll know they're not taking it because they won't pick it up from the pharmacy. Just some details on that. Clinical monitoring. You need to tell every patient, as we did in CHUK, if you develop any of these symptoms, fever, headache, rash, fatigue, dark urine, persistent numbness in your hands, you need to stop taking the medicine. And this is why we only give, if you're doing 9 months of INH, only 1 month of medicine at a time. They come in every month, you weigh them, you ask them their symptoms, and if there's no symptoms, you continue on with therapy. The quickest way to land in court with a malpractice is you didn't bring the patient back in, you gave them 9 months, and at 6 months, they had liver failure. You have no leg to stand on. You did not do what is considered standard of practice, monthly monitoring of these side effects, okay? And I say that because it happened right here in this part of the country, okay? Brief exam, talking about these symptoms, and you look for hepatitis. Again, hepatitis B and C in this population is not very high. It's uncommon in kids under or people under 20. It's not that high in 50 to 64-year-olds. And the biggest risk factor for many of us will be heavy alcohol consumption. So baseline functioning tests aren't necessary for every single patient, only those with these risk factors: history of liver disease, regular alcohol use, pregnancy, or HIV infection, okay? And, repeat the labs if they're abnormal, but you watch carefully. You could still treat someone with elevated liver enzymes. I would do that in harmony with someone who's used to doing it, meaning call the public health department or talk to an ID doc. We still treat people with a elevation of their ALT as long as they're not having symptoms. Okay. 3 times upper limit of normal, 5 times if they don't have any symptoms. Okay, there we go. Now that was your crash course on TB, the most important of all the diseases in our foreign-born population. And I think if you use that template, you use those resources, you could make a business out of doing foreign-born evaluations. So thank you. Yeah, we'll bring the mic around for those on the.
Hi, thank you for the talk. I'm Ed from Hospitals in Tacoma.
Yeah.
In the world of shared decision making in our country, or particularly our state.
Yep.
I want to ask you a question about a patient that was important because she was from another country, in her 40s. She was screened for TB, I believe had a BCG in her country. She had a PPD positive, which was strongly positive, and had quantiferin gold, a chest x-ray negative.
What was the quantiferin?
Pardon me?
What was the result?
Positive.
Positive. Okay.
It was. She was asymptomatic.
Yep,
Her physician recommended treatment
yep,
for latent TB.
okay,
The moment she heard the word TB,
yep,
she filed a complaint to the organization and besmirched the physician considerably. He was dragged through the mud because she claimed that the diagnosis demeaned her. She disagreed with the diagnosis and refused treatment. Your recommendation?
yeah. So here's the catch-22 in Washington State. Public health has the authority to compel someone to get tested for TB and treated. And if they say no, then you go to jail, as Tacoma knows very well. But there is no authority for latent TB infection. So you are, as you probably figured out with this, high and dry. What I think, and part of before I retire, is I'm going to make latent TB infection a notifiable condition. So I will make this go away, because in the meantime, it does exactly this. You get patients that disagree with the diagnosis, they badmouth the healthcare system. Everyone's a loser, and she's got a 10% risk her entire lifetime of developing disease. So if she doesn't have it now, she lives long enough, we might have to treat her as a case. I see these cases over and over and over in this state that were diagnosed with latent TB infection, refused treatment, and now 10 years later, they got full-blown TB. So unfortunately, it's a catch in the system, because latent TB, and it's not really reportable in many states at all. I am going to push us to make that a reportable condition to help with that. Sorry that happened to you guys. Sorry that you also had in Tacoma a woman who had active disease who refused treatment. And that was in the news, and she got put in jail. And by the way, we can't force you to take TB meds, but we can force you not to be in public to expose other people. So take your meds or go to jail for the rest of your life, or in the rest of your time that you could be infectious. It's your choice. And sometimes people with behavioral health issues or substance abuse issues, they really fight you quite heavily. So yeah, sorry about that for your county. Any other questions? I will, I know we're over time, so I will stick around for a little bit.
Yeah,
if
quick
anyone-
question.
Yeah.
Patient would have 6 months treatment. They want to know whether they need to complete 9 months.
Yeah, you know, what recommendation do we give? Hey, treatment is 9 months, but 6 months is okay.
Yeah.
TB,
So
it's
we have
so
people
frustrating.
who had treatment before, and now we tell them 9 months. So
Yeah.
what do you do with those?
Yeah, I would say I'm conservative with people that are from a part of the world where there's a lot of multi-drug resistant TB or high resistance, or if this individual had really heavy exposure to a case of TB. If they're just someone you're picking up with a positive IGRA or something, 6 months is fine as long as all goes well and you know they took their meds. 9 months is preferred in high-risk situations. So that's the best I can give you.
Lights, because we have a lot of population, like they refuse treatment. So what I do is I do annual chest X-ray. But in the slides there, it said no follow-up for latent TB, because this should be annual X-ray after diagnosis. If they, because we have some, especially I have some patients who come from Europe,
Yeah.
Ukraine, they don't want treatment. They said, I'm not, don't symptoms. So how do you follow them? I just do annual X-ray, because then you, I
uh,
mean, there's problem that they can infect his whole family. Or
Yeah,
like-
I'm a fan of PAs. I'm not a huge fan of lateral unless you're an infant. Infants should get PA and lateral because your adenopathy won't show up unless it's on a lateral. But, you know, I think it is, do you have a good relationship with this patient that may not speak your language? So you got to have someone who is an advocate for that patient that speaks their language, and you do the best you can to explain why it's important. I have had, not that this is critical, but Russian patient once tell me, it's like, you American doctors, you're like, well, you got a positive skin test, but we don't see anything. So it might be infection. So it might not, just tell me what to do. And I was like, yeah, we are kind of wishy-washy. So I tend to be a lot more pragmatic now when I talk to patients, but I'm compassionate, I'm straight up, And at the end of the day, for latent TB infection, I let them make their choice. But if they have active disease, you don't get a choice. I try and explain to them, yeah, I know you don't want treatment, you don't want this x-ray, but we have the authority to do it and we're gonna do it. Your choice will be stay in prison or take your therapy every day. So it's all about relationships, Jimmy, and speaking the right language. One of the big reasons I went back to Chuk is we have a very large Marshallese outbreak in Washington State. And I'm having a hard time convincing people with positive skin tests, so high area of endemicity that have been infected. I have a hard time getting them to convincing them to take their treatment so that they don't become a case down the road. And I'm probably on my 10th patient who refused therapy and now they're a case. And it costs. Who pays for TB in this country, by the way, in this state? Who pays? The payer of last resort is the county health department in every county. So Larry, all those years you were at Benton Franklin, if you had a multi-drug resistant case that would have cost $1 million, did you have the budget for that? Nope. So this is how vulnerable we are. So I really work hard when we get these cases to make sure they're covered and that patients understand why they need to take therapy. Yeah.
Quick question.
Yeah.
I work in Yakima. Are
Mm.
H2A farm workers
Mhm.
screened for TB prior to coming?
They are. Well, not prior to coming unless you're in certain categories. A lot of people come without the government knowing. So no, they are not screened. They
Well-
come as students. They aren't necessarily screened. I think the large majority of folks that come not just from Mexico to Yakima, et cetera, are not tested. Some of the farm workers will do a really good job of making sure that they get tested, both for COVID and
Is
TB.
the employer screening them then?
Some,
Because
in
they
some
contract
cases.
with the employers.
The state TV program really encourages both financially and operationally to do it. Now, look, if I can go hut to hut in Chuk, there's no reason we can't do the same thing in Yakima. There's no excuse. Have an x-ray. Man, I took x-rays. I'm not an x-ray tech with a machine that is this big. You know, you hold it like a big camera and then there's a plate and you just have the patient, hey, your skin test positive, click, click. And then I look at the x-ray and say, hey, you need to be treated. By the way, here's the treatment right here and there. So within 20 minutes, I can take care of it. What happens in places like Yakima or any place is they get a positive skin test. The healthcare system freaks out. It takes them a month to get an appointment. Then we send them for an x-ray and that x-ray takes another month or 2 months or unacceptable. We need to get better at this. So this is what I meant by learning from these experiences in developing countries. This is the technology we need to bring here. Wouldn't you want these x-ray machines are $62,000. That's not that expensive. We could do these in our offices. We could put them in the Yakima Valley Farm Worker Clinic. So I think we need to start thinking differently about this. So not using Yakima as the poster child, but that's one example. Yeah. Okay. And I'll stick around for a little bit if anyone has any questions, but don't want to hold you all up. That was a long day. Good job. You made it through the first day.